On August 12, 2021, the FDA amended its emergency use authorizations for the Pfizer and Moderna COVID-19 vaccines. Immunocompromised patients could now receive a third dose. And within 24 hours, the CDC recommended booster vaccines for these patients. This has led many clinicians to receive questions from their immunocompromised patients. Should they get a booster? What vaccine should they get? Should they pause their medications while they receive the vaccine? Will the symptoms of their disease reemerge once vaccinated? Until recently, there hasn't been much research to help clinicians answer these questions. But new evidence is beginning to reveal how effective these vaccines are in immunocompromised patients. The initial COVID-19 vaccine trials excluded immunocompromised patients, such as those with rheumatic diseases like rheumatoid arthritis or lupus. So it wasn't really clear how effective the vaccines would be for them. But now we do have a better idea. Recent studies suggest that 38 to 60% of immunocompromised patients develop anti-SARS-CoV-2 antibodies after their second dose. In contrast, almost all immunocompetent people developed these antibodies. Immunocompromised patients also had lower antibody titer counts compared to immunocompetent people. Let's dig into this a bit more. Here's a preprint study that focused on patients with chronic inflammatory diseases. It showed that these patients had a threefold reduction in antibody titers than in immunocompetent people. B-cell depleting agents like the drug rituximab had the most negative impact on titers, causing a 36-fold reduction in humoral response. And glucocorticoids are almost as bad, causing a 10-fold reduction. But we also know that T-cell mediated immunity is an important part of the vaccine response. It can be activated in patients with low B-cell populations, and it's not measured by antibody titers. Honestly, it isn't clear what these titer levels mean at a clinical level, and it might be worth sharing that unknown with your patients. But there is good news. Administering a third dose of the COVID-19 vaccine does look promising for immunocompromised patients. A study by Schroff et al. Evaluated the immune responses to the Pfizer vaccine in solid tumor patients who were on cytotoxic therapy. They found median PRNT90 titers of 20 after the first dose in cancer patients, median titers of 60 after the second dose, and median titers of 180 after the third dose. In another non-peer-reviewed study by Kamar et al., transplant patients showed a 4% antibody response after the first vaccine dose, 40% after the second dose, and a 68% antibody response 4 weeks after the third dose. Of the people who didn't have COVID antibodies before the third dose, 44% did develop antibodies 4 weeks after the third dose. Patients who never developed antibodies tended to be older with higher immunosuppression. As a quick aside, while all these studies are promising, they're early in the review process. So keep that in mind when making clinical decisions. And if you like how we break down clinical results, get subscribed. We'll be looking at the FDA's recent approval of anifrolumab in an upcoming video. So based on this early research, the CDC and the FDA have decided that immunocompromised patients should receive a third dose. But when should the vaccine be administered? Many of these patients have complicated medication schedules. Well, the American College of Rheumatology has provided valuable guidance on this exact topic. In the case of second and third doses, the college recommends holding all medications, except for glucocorticoids and anti-cytokine therapies, for 1 to 2 weeks after the shot if the patient's condition allows. Dr. Anisha Dua is an editor for Figure 1's rheumatology newsletter, The Differential, and is an associate professor of medicine at the Feinberg School of Medicine. In her recent newsletter, she says she's been continuing most treatments for her patients, but if patients can tolerate it, she holds methotrexate, Janus kinase inhibitor 1, mycophenolic acid, and azathioprine for 1 week post-vaccine. Dr. Dua says that rituximab is the hardest drug to hold. For patients on 6-month infusion schedules, she tries to push the infusion back while monitoring B-cell counts. If she's concerned about disease flare or sees B-cell repopulation, she recommends patients get the COVID-19 vaccine 2 weeks before the rituximab infusion. And for patients with active disease, she recommends continuing rituximab as scheduled, but to get the booster 5 months after their last rituximab dose. If that's not possible, they should just get the booster whenever convenient for them. So in summary, research suggests that immunocompromised patients don't respond as well to the first and second doses of the COVID mRNA vaccines as immunocompetent people do. To improve protection, the CDC and FDA now recommend that vulnerable people receive a third dose. New studies are showing promising results that a third dose will improve immunity for these populations, but the research is still under peer review. And finally, the American College of Rheumatology has also released guidelines to help clinicians manage vaccine and patient medication schedules. Thanks so much for watching. If you want to read Dr. Anisha Dua's newsletter, or look at the sources we used in this video, we've left links in the video description. If you want to watch more COVID-19 content, we recently made a video about COVID-19-induced erythema. And don't forget to check out figure1.com, where you can browse through thousands of patient cases posted by the community.